Well, since we already started a little bit late, I'll go ahead and get us started. My name is Dr. Ijeoma. Last name is Eco, like eco-friendly. A patient actually taught me that, which is crazy because it's been my name my whole life, right? But I am the newest member of Institute for Human Reproduction, or IHR, which is one of the Pinnacle clinics across the country. I just joined about a month ago, a recent graduate from fellowship for infertility. The fellowship is called Reproductive Endocrinology and Infertility, so REI. But not the store we know and love, but REI training, and then I moved back to Chicago. So happy to be here. The way we'll start the session is by addressing questions that were sent in at the prior to the session start. But if you have questions that you have, please feel free to jump in at any point, and then I can address them. If there's anything that's really specific, we might say that might be better for like a one-on-one visit, but I'll try my best to answer the questions as I'm able to. Okay, so we'll get started. So in terms of who needs to see a fertility provider, so we think about it broadly, people who can't conceive on their own. So if you need a donor egg, meaning there's no one to provide an egg, if you need, I gotta keep my thumbs down. If you need donor sperm, if you need someone to help carry the pregnancy for you, there are also individuals who are single parents by choice, and so those people would fit into the category of needing some sort of donor tissue, whether it's sperm or egg. For individuals who have a sperm and egg present in the couple, then we're looking at least a year of kind of regular intercourse. It doesn't have to be something that you're tracking it. A lot of people will say, well, we haven't done anything to prevent pregnancy, but we haven't been tracking it. But all that time counts, so a year. If the person with the ovaries is over the age of 35, then we'll say 6 months. This is because we know that there's it's not like your ovaries know exactly when you turn 35. You're not all of a sudden losing all your eggs, but we know that there's an increased rate to which the eggs kind of decrease in number, and increased rate of eggs that have abnormal genetics. And it's abnormal genetics that make it harder for individuals with ovaries to get pregnant as they get older. So we don't want to wait a year for those individuals. And then really, I start to think about patients 39, 40, 6 months, I think is too long, especially if they haven't had a chance to start building their family just yet. So we say, talk to your providers, your OB/GYN to get a referral, or if you can self-refer, see a fertility specialist to have the discussion. And then most importantly, I would say, if you have questions about your fertility, I don't know many patients that would have any kind of regrets about talking about it sooner. So even if you're less than 35 with ovaries and it has been less than a year, but there's something going on, please, we're happy to see you to just kind of talk about what fertility looks like. And then one important category I'd like to say, because I feel like it's not as intuitive as we think it is if you're not having periods. So sometimes we'll see patients, or I've seen patients that will say, I've been trying to get pregnant for the past 3 years, but I haven't had a period this whole time. So you have to have periods or bleeds to be able to get pregnant. It's a sign that the body released an egg. And so if you're not having any periods, that's another reason. Or if you're having fewer than 9 periods in a year, it's a reason to see either an OB/GYN or see an infertility specialist, so we can talk about one, how to keep you healthy, because that increases the risk of cancer of the uterus. Oh, there I go with my thumb again. And then two, if you are trying to get pregnant, then we want to think about what we can do to help you release an egg every month. And there are things that are not IVF that we can do, because I think IVF scares a lot of people. I understand why it's scary, but it's a great tool that we have if you need it, but it's not the first thing that we have to jump to. So that was one of the first questions that was asked. Okay. Other questions that were asked were about IUI versus IVF. So just to kind of describe what those are, IUI is intrauterine insemination. It's what I think of, or I think a lot of people think of as like the turkey baster method, but like in the doctor's office. But with an IUI or intrauterine insemination, what's happening is that if this is the cervix, actually let me grab a catheter. I have some plain ones here. Okay. All right. So if this is the cervix and this is a catheter, it's pretty thin. What would happen is you would have a syringe on this end that would have the sperm sample, whether it's donor sperm or from a partner that's in process in the lab, to kind of get away any debris and to help activate the sperm. That's put through the cervix into the actual body of the uterus. And then the sperm is deployed with like a plunger. And that helps put the sperm closer to the actual fallopian tubes. And the way that that is helpful is it's helpful for people who do not have regular periods, and we're giving them medications to help release an egg if they haven't gotten pregnant with timed intercourse. And then for people who do have regular periods, and regular periods would be anywhere between 21 to 35 days apart every month, we give you medication so you release more than one egg at a time, and that's called superovulation. So you're not just ovulating, we're superovulating because more than one egg is being released. We'd add on this IUI method, again, to bring the sperm closer to the fallopian tubes, which is where fertilization takes place. The way I think about this being helpful is that sperm with intercourse are just deposited at the top of the vagina. And even though on the body, it's not that far to go from the vagina to the fallopian tubes, like the distance isn't very short, or isn't very long, I should say. For sperm, because they're so small, we're here in Chicago, so I guess a reference might be me in Chicago trying to run to Indiana. That's the distance that sperm have to go. And I don't know about you, but I don't run unless I'm being chased, and there's no way I'm making it. The sperm are better than my athletic prowess or lack thereof. So they make it, but very few make it compared to how many were deposited in the vagina. So if you bring them closer to the fallopian tube, that helps it increase a chance that the right sperm and the egg can come together and then lead to the early pregnancy, early embryo. So people who benefit from IUIs, we already talked about, if you have irregular periods and you haven't gotten pregnant with medication that helps you have a period every month, and timed intercourse, just intercourse at home, kind of tracking your cycle, or if you have periods that are regular, and we give you medication to help you release more than one egg at a time, then we would add on the IUI. So those individuals benefit from it. If you have at least one open fallopian tube, if there's sperm that's a certain number, like kind of cut off, and every lab's a little bit different. If you have enough sperm, you can do it. If there are too few sperm, it's not going to be the right choice for you. And if both your fallopian tubes are opened, so you mentioned that's where fertilization takes place, then IUI wouldn't be the right choice. Thinking about IVF, IVF is right for everyone who's tried the other things we've talked about, but haven't gotten pregnant. And the number of cycles that you would try for other treatment will vary. Based off of your medical history, your age, and also you have to think about cost and insurance coverage. Sometimes we're doing things because insurance asks it of us so we can get things covered. IVF can be helpful for people who, again, few sperm, if their tubes are blocked, if they have any genetic conditions that they are hoping to screen early embryos for. Again, it's not a diagnostic test, it's not a perfect test. It's a pre-implantation genetic testing, abbreviated PGT. So it's a kind of a screening exam we can do on the embryos to decrease risk of passing something off to offspring. And then individuals who are older, they benefit from moving on to IVF with this genetic testing because we can find the embryo that is genetically normal. And it's that genetically normal embryo, and the term that we use in medicine is euploid. So genetically normal embryo where it got the right number of genetic material from the egg and the sperm. those are the ones that are most likely to lead to a pregnancy. So IVF allows us to do testing on the embryo. We can't do testing on egg or sperm to know the genetic kind of health in terms of if there's the right number of or right amount of genetic information. Okay. So other questions would be, okay, you were able to give birth, amazing. Maybe it was a vaginal delivery, a C-section. How long do you have to wait for another IVF cycle? So if it's just an IVF cycle and not a transfer, the answer will vary. And it also varies based off of the complications or lack thereof in the pregnancy. So if you had a normal vaginal delivery, no complications, the recommendations will vary. So talk with your OBGYN and the infertility clinic that you're seeing. But it can be somewhere between 6 months to 18 months, kind of depending. And then for a C-section, it's similar. The concern about a C-section is that it's major surgery, so they had to place an incision into that muscle, and we need time for it to heal before getting you pregnant again. The risk is that if that muscle isn't healed, then it can lead to something called a uterine rupture where that muscle opens up. So it's not that we're trying to be mean and keep you from that next transfer. We're just trying to keep you safe, because the most important thing is that we keep you safe because your babies need you around. And then we want to protect that pregnancy as well. So again, it's a range, and so it's going to vary on your medical history. Something else that will be important that is a little bit clinic dependent is breastfeeding. So some clinics feel comfortable starting individuals on stimulation medication, meaning like the IVF medications, to get more eggs if they're breastfeeding. The thing to know is that can often shut down your milk production. So if you're hoping to breastfeed for 6 months, a year, sometimes people can rebound from that and come back and their milk supply replenishes itself, but sometimes they don't. So just speaking with your provider, and then it's a very personal decision, but your provider can help guide you as to like the next steps. Okay. And then this is one of my favorite questions. Do you need to rest after embryo transfer? You're probably going to hear different things. So the way I counsel my patients and my training was that you don't need to rest after an embryo transfer, right? It's not going anywhere. If you haven't had an embryo transfer before, it's kind of like the whole process is very similar to the insemination or the IUI that we talked about. There's a catheter that goes into the cervix, but rather than sperm on this end, there's a little bit of fluid that we like media fluid is what the embryologists call it, and the embryo's in there, and then the embryo gets deposited into the uterus instead of sperm. We use an ultrasound usually to look because we want to place it at a certain place. So all that to say, the embryo is kind of stuck there. We think that it starts to implant immediately. Embryos are sticky, so they're looking for somewhere to take up. So you kind of getting up right after the embryo transfer to use the bathroom. We don't think it's going anywhere. One of my favorite attendings in training, it's like supervising providers in training, used to say that you can take an embryo anywhere. One of his patients said that they were going on a motorcycle ride from Utah to Vegas right after the embryo transfer. I don't necessarily say that I condone the motorcycles because they're so dangerous, but that's unlikely to affect your chance of pregnancy, whether it's activity that you usually do. So if you're an active person and you like to run, that helps you with stress. If you're someone who likes to walk, all those like daily activities, sometimes people will say, can I pick up my other kids? If it's something that you've been doing in your daily life, it's okay to continue in terms of activity. The things that we say not to do would be nothing in the vagina, at least in my practice, nothing in the vagina, no orgasm, until that first blood draw where we confirm if early pregnancy is present. Usually that's about 12 days after the transfer, so let's say like 2 weeks. And you're going to act as if you're pregnant. So you're going to take your prenatal vitamin, which hopefully you were taking already. You're not going to drink, you're not going to smoke, you're not going to start to take up any hard drugs. And then being in Illinois, a question that we get all the time is about marijuana, and I would say that my strong recommendation is to stop marijuana while you're trying to get pregnant, and definitely not to resume it once we're at the embryo transfer phase. But activity-wise, you being on bed rest other than driving you mad, I don't think that it's doing anything. So again, talk with your providers. This can be something that different clinics have different opinions on, or different providers, and that's okay. I don't think it's harmful to rest. So if it makes you feel better to rest, you should rest. If you want us to tell your partners that you need massage every other day, but really you can go back to your day-to-day kind of activities. Let's see. And then, do we think that infertility is more common than ever? I think that's a really hard question to answer. So when we think about the statistics that we say like 1 in 5, 1 in 6 individuals in the world is affected by infertility. It's super common. It could be that it's more common, or it could be that we are more mindful about it, that people are seeking treatment, that there are better treatment options. It used to be that we were not very good at this, and we're still, have leaps and bounds that hopefully will improve in our success rates. But I think more people are getting diagnosed, and luckily there are a lot of states where infertility coverage is now present. And so people who maybe wouldn't have been able to seek care or even arrive at the diagnosis of infertility are getting that diagnosis, and hopefully then getting the treatment. So in my personal opinion, I see it as a possibility that there is decreased fertility, but again, it's completely opinion just based off of my interest in the environmental sciences and like pollutants. But I can't say that we have clear evidence to say for sure that infertility is on the rise. So, and that's a wishy-washy answer, but hopefully that helps. And let's see, what other questions do we have? Okay. Does pregnancy success increase after every transfer? And a question also includes, what about the inclusion of the endometrial receptivity assay, or ERA? So the first part of the question asking about pregnancy success rates. So if we have a euploid embryo, and again, euploid means that the embryo is genetically has the right number of amount of genetic information. I think is the simplest way to explain it. What is the chance of success? So with the first transfer of a euploid embryo, which means that we did that PGT, pre-implantation genetic testing for aneuploidy, there's about a kind of a 50 to 65% chance of a live birth, meaning that you take home a baby, not just a positive pregnancy test, which I know we're excited about, but what we really want, obviously, is for you to take home that baby. If it doesn't work that first time, it's kind of like a little bit like flipping a coin in terms of the odds of success, the chance of success. And you do another transfer, so you do a second transfer, again with a genetically normal embryo. The chance of success is about 85%, meaning that most, the vast majority of patients who have 2 genetically normal embryos, and there's nothing else that we can find to decrease the chance of the embryo implanting or the pregnancy continuing. 85%, that's a great number. It's not 100, that's still 15% of people that had all the things going for them, and we just don't know why. Realistically, we think that probably there's something genetic that we're just not able to test for that went wrong. If that same individual has a third transfer, there's about a 95% chance of success, which is really great. So we'd say that the vast majority of individuals who have genetically normal embryos, they undergo a transfer, whether it's 1, 2, or 3, the odds are in their favor that they're going to be able to take home a baby after that. Individuals will ask about this endometrial receptivity assay, ERA, and this is kind of a hot button topic in our field. My personal kind of thoughts on it based off of the evidence that we have and the way that I counsel my patients is that for that good prognosis couple, meaning that there's nothing else that we can think of that's standing in the way of them getting pregnant, and we have a genetically normal embryo, I do not recommend doing the ERA. One, because it's not covered by insurance, so you're going to be paying out of pocket for that. If you wanted the information, talk with your provider about doing it with that first transfer. I think it's unlikely to cause harm, but this process, even if you have insurance coverage, for a lot of people, there's still something that's coming out of their pocket, and it's expensive, and we want you to have kids, and we know that's expensive. So I'm just trying to be mindful about kind of the cost and the benefit. Let's say you have 2 embryo transfers, 3 embryo transfers, and they don't take, meaning you're not pregnant or you don't continue to have a live birth and we don't know why. I think reasonable to talk to your provider to see if it's something you should consider. Again, I think there's low risk of harm with that testing. It's just, I don't want to market anything to you that I'm not sure about in terms of the success rates, and all your providers will feel the same way, but the literature can be interpreted different ways. So that's kind of my stance, but my strong recommendation is that you have a full discussion with your provider and review your history, right? So everyone's different. No one is a textbook. So even though we think that it should be 65, 85%, 95% chance with 1, 2, and 3 transfers, it's not the same for everyone. All right. And then for this individual, the question is, in a situation in which you have stored embryos but had to have a hysterectomy or removal of the uterus, and what to do with the embryos. I would say that is, I'm so sorry that happened to you. That's one, I'm glad that you had for your embryos safe and sound, but that must have been a big deal. You're not the only one who's in that situation, so it's something that we deal with. So what to do with embryos? The question is what to do with your embryos in that situation. There are a couple of things you can do. If you were still hoping to build your family, there's so many ways to build a family, and it doesn't just have to be kind of like a sperm, egg in your body growing it. You could think about using what we call a gestational carrier. So that's where the embryos would be transferred into someone else. It could be someone that you know. So someone that you know that's been medically cleared by the fertility specialist or an OB/GYN. Or it could be someone that you find through an agency. And then again, they have like kind of strict criteria that we try to follow to make sure that we keep the person who's volunteering for that service to carry the pregnancy safe. And also you want a safe pregnancy or baby for you too. So that's an option. If you're not interested in building your family using your embryos, then you would speak with the lab or the storage center that has them and let them know that you're not proceeding with kind of building your family and what the next steps are. The way that prior clinics I've been at have done this is we would allow the embryos to thaw, or you might have special wishes. Again, different clinics have different things that they're able to do, but there's no situation in which you should be kind of forced to use embryos if you feel like you've completed your family building. But I think it's a really good time to then have a follow-up visit with your fertility specialist, because most likely they're not the one who did that surgery. Let them know what happened, to have an update, and then discuss the options based off of your family planning goals or building goals, and the actual clinic that has the embryos. Okay. Let's see. So I'm going to circle back because we had, I know we talked about it before, but maybe I think some people logged on and are interested in it. The question is about, again, giving birth and when you can proceed with a cycle again. And my answer was kind of wishy-washy because there's a lot of kind of opinions about this. So the general range is about 6 months after a delivery to 18 months, whether it's vaginal or C-section. For a vaginal delivery where there are no complications, meaning no heavy bleeding, no significant vaginal tear, the mom wasn't sick during the delivery, so things like really high blood pressure or kind of other things that can be complications in pregnancy. If all those things didn't happen, then we can kind of consider using your age and other risk factors if that shorter window, so closer to 6 months to 1 year, is appropriate. So you would talk to one, your OB/GYN, and then to your fertility specialist. For people with C-sections, as you mentioned, a C-section is major surgery. So if my fingers are the uterine muscle, to get to the baby for a C-section, we have to cut through that muscle. The uterus is a really resilient muscle, so it's sewn back together and it can regain its strength, but it takes time, right? So we usually counsel longer, so somewhere between like 6 months to 18 months, even if it was uncomplicated, often close to that 18-month period of time for another pregnancy, meaning another transfer. But if the question is when you could do a stimulation, meaning in vitro fertilization, where we get more eggs, hopefully make embryos, and then freeze embryos to use in the future, then really the factor that will determine when you can start is if you're breastfeeding or not. So usually a couple months afterwards, just allow time for the body to recover. If you're not breastfeeding, you can start right away. If you're okay with the kind of the chance the breast supply or the milk supply, decreases with the stimulation, some clinics will say go ahead while breastfeeding. Some clinics feel strongly that you should stop. So that's something where you'd have to talk with your provider. But there's again quite a range, and so the things to consider would be: was the delivery complicated? Was it a vaginal delivery or C-section? And then are you breastfeeding? And what are kind of your concerns about the breast supply decreasing in the setting of the hormone levels changing in your body? Okay. And then another question. So because it's Breast Cancer Awareness Month, as we all know, a question, we'll talk about some breast cancer related things. A question a lot of our patients will ask us because again, it's on the mind. You know, we all know someone who's been affected by breast cancer, if not personally so. And undergoing fertility treatment, as to the best of our knowledge, based off of current evidence, does not increase the risk of breast cancer. If you have a history of breast cancer, that's something where you would talk with your cancer provider and the fertility provider to see things that we could do to kind of decrease the risk based off of the type of breast cancer. Some breast cancer is sensitive to the hormones that increase during the stimulation, and some are not. But just having undergoing an IVF cycle itself does not increase your risk for breast cancer on its own. Another question that people have is if you already have or had breast cancer in the past, what to do. And as we mentioned, speak with your provider. It doesn't mean that you can't. For patients who are newly diagnosed with breast cancer, a strong recommendation that we have is that you do see someone to talk about preserving your fertility, because a lot of that treatment, depending on the stage and the type of cancer, if it involves radiation, that's usually less concerning because the radiation is usually targeted to the top half of your body and only some of it can affect the ovaries. But if it's chemotherapy, meaning medication that goes everywhere in your body, depending on the type of chemotherapy, it can really damage the ovaries, not just the current state of the ovaries, but leading the ovaries to run out of eggs faster. So it can damage the eggs, and then it can make it so that you go into menopause sooner, if not right after the treatment or with the treatment that you're undergoing. So seeing a fertility provider, it doesn't always mean that the cancer doctor would recommend you undergoing the treatment, but because I think it's really hard to have undergone that treatment and never know what your options are. So I think every patient deserves to be able to hear what their options are, even if in the end the safest thing for them to do is to not delay the cancer treatment and start. I think usually it's about 45 minutes to an hour long conversation, and a lot of clinics at this point could do it remotely, so virtually. So if you're already like in the hospital, kind of getting plugged into care, my hope is that there's some facility near you that could talk to you, so you can at least hear your options. But there are a large number of patients who have active breast cancer that would go through fertility preservation if there's enough time. We use the medication and oral medication to decrease the level of estrogen in the body for these patients and for other patients who have like active cancer. There's a theoretical chance that works, so we use it because it's a safe medication. It's actually medication that people use to decrease the risk of breast cancer, so it's been very well studied. But I would say that again, even people who have active breast cancer are undergoing fertility preservation, getting their eggs out, either freezing eggs, or if they're ready to make embryos, doing that. Something that was really interesting that I learned not that long ago is that individuals who have the breast cancer gene mutation, or the BRCA or BRCA mutation, they actually have an increased chance. So those individuals, let me step back, have an increased chance of breast cancer and ovarian cancer. They also have an increased chance of having fertility issues, and because they have an increased chance of running out of eggs faster. So early or premature menopause. And so those individuals should be counseled that if they are positive for BRCA or the breast cancer mutation gene, to talk with a fertility provider if they think that they might want children of their own, so that they can consider, if they're not ready to have children at that time, they can consider doing egg freezing or creating embryos to possibly use in the future. Because God forbid there's a cancer diagnosis before they get to that family building or finishing their family building, then at least there is a possible option for them to use to complete family building in the future. Okay. All right. So I think that kind of wraps up the questions that we've had so far. Thank you again for bearing with me. I apologize again for that late start that we had. Again, girls first, Instagram Live, hopefully it was okay. Thank you so much for taking the time to join. If you have additional questions or are interested in talking more about your fertility journey, I'd be happy to see you. Again, my name is Dr. Iko, and I'm the newest member of Institute for Human Reproduction, or IHR. And I can say that I joined this clinic because it just felt like a family. All the providers here are so kind and so thoughtful. We work as a team to take the best care of our patients. We have a wonderful nursing staff and office staff and sonographers. So it's so pleasant for me to be here. And I think that environment, it's already really hard, or it can be a really challenging journey. We'd be so happy to help you along the way. So please reach out to schedule if you have any questions, or if I can help you. I'd love to be part of your family building journey. Thank you.